Medhub. This is our first ever video and we are going to be looking at hypertension. We are going to be doing various topics, but today it's hypertension. So let's just dive in. So hypertension, by definition, hypertension, this is a persistently elevated blood pressure. In fact, it's a persistently elevated resting blood pressure. Resting blood pressure of greater than or equal to 140 out of 90 millimeters of mercury. Yes, persistently elevated resting blood pressure of above or equal to 140 over 90 millimeters of mercury, measured twice, 5 minutes apart, on 2 or more occasions. This is usually 1 to 3 weeks apart. So we measure the blood pressure when someone is resting. We take 2 or more measurements, but they are 5 to 10 minutes apart, but they are also measured on occasions of 2 to 3 weeks apart. So whenever the pressure is persistently elevated and all that criteria is reached, we diagnose someone that they have hypertension. Hypertension in simple terms is an elevated arterial blood pressure. So we are going to be looking at the risk factors, the types of hypertension, the pathophysiology of hypertension, the mechanisms by which hypertension develops in an individual. We'll look at the consequences or the complications that may arise in case hypertension is not properly managed, and we will also look at the crises and also the management of hypertension, together with the signs and symptoms that may occur, or the ones you may find in someone with hypertension. But before looking at all that, let us first recall hypertension is high blood pressure. So let us first go back and look at blood pressure. So blood pressure basically, this is the force blood exerts onto the walls of the arteries as it is passing through. You get the arteries, they have another lumen, as we all know. So the force exerted as blood is passing through our artery, the force it exerts onto the walls of this blood vessel is what we call blood pressure. Yes, and blood pressure is one of the vital signs all individuals have. Among others, the temperature, pulse, and all that. We have our vital signs, but among those is the blood pressure. And blood pressure is very, very important in that when we take someone's blood pressure, it tells us of is the body getting enough blood? Is there enough perfusion? Is the perfusion adequate to sustain the organs that are in the body, the brain, the liver, and other organs? So that's the blood pressure, the force exerted onto the walls of the arteries as blood is passing through. And blood pressure is usually denoted as 2 figures, X out of Y. X indicating the systolic blood pressure, meaning when the heart is contracting, the pressure in the arteries. Then the denominator is the diastolic blood pressure, the pressure in the arteries as when the blood vessels or when this artery is relaxing. You get. So we're going to look at the normal values, but usually the normal values of hypertension in a healthy adult are usually less than 120 for the systolic and less than 90 for diastolic millimeters of mercury. So blood pressure in a normal individual without blood pressure is usually regulated by certain mechanisms. We're also going to first look at how this blood pressure is regulated. You get. So before you come to the regulation of blood pressure, let us first look at blood pressure itself is a product of cardiac output times the total peripheral vascular resistance. We are going to go into a deeper dive of cardiac output and vascular resistance when we are looking at the mechanisms by which blood pressure comes about. But here, let us first look at this. And cardiac output is further as a result of stroke volume times the heart rate. So stroke volume, this is the amount of blood that is squeezed out of the heart whenever it beats. In only one beat, the volume of blood that is squeezed out is what we call a stroke volume. And then the heart rate, these are the number of times the heart beats in 1 minute. So basically, blood pressure is equal to stroke volume times the heart rate times the vascular resistance. And yes, blood pressure is directly proportional to the stroke volume, to the product of the stroke volume, heart rate, and the vascular resistance. So anything that increases this increases our blood pressure. You get. And also in the regulation, we affect these such that the blood pressure is maintained in the norm. And also when we look at the medications we will use to treat hypertension, they will be affecting either stroke volume, heart rate, or vascular resistance to manage our blood pressure. So as I've told you that blood pressure, the normal ranges are usually less than 120/90. So how does the body manage this blood pressure to be within this normal range in a healthy individual? So we are going to look at the regulation of our blood pressure. So this is regulation. So the regulation of blood pressure involves an interplay of various systems. The autonomic nervous system plays a crucial part in the regulation of the blood pressure, and also what we call the RAS, the renin angiotensin aldosterone system. Though one is a short-term, another is a long-term regulatory mechanism. So for short-term, this one usually comes into play whenever we have a sudden drop or rise in the blood pressure. So for us to bring that blood pressure back to the normal, to maintain the perfusion of these organs, short-term regulation comes into play, and this one is usually due to the baroreceptor reflex. So we have baroreceptors in the aortic arch and also in the carotid bodies, or in the carotid sinuses. In the carotid artery, we have what we call the carotid sinus that has the carotid bodies. We have baroreceptors there. So whenever there is for example, whenever there is a sudden drop in the blood pressure, the stretch of the aorta and the aortic arch and also at the carotid sinuses will not be the normal, like the stretch will not be of the normal blood pressure. Remember, force exerted onto the walls. So the force exerted onto these areas will be reduced. So that will be picked by the baroreceptors in these regions. They will send information to the brain, and the brain will in response, will let out what we call a sympathetic outflow. Sympathetic. This one involves epinephrine, which is goes to the heart and the beta 1 receptors, increasing the heart rate and also the blood vessels, leading to what we call vasoconstriction. So the lumen will narrow due to the sympathetic outflow. It will narrow, what we call constriction. You get, maintaining now the heart rate. The same thing happens whenever we have a sudden rise in the blood pressure. Still, the force on which is exerted onto these baroreceptors that are found in the aortic arch and the carotid bodies will be elevated. So still will send impulses via the glossopharyngeal and the vagus nerve. They will send impulses to the certain nucleus in the brain, and in response will pump out what we call a parasympathetic we'll have what we call a parasympathetic response. This one leads to release of a neurotransmitter called acetylcholine, and its response, it is that of rest and digest. And whenever we have that, we'll have the heart rate decreasing, and we will also have what we call vasodilation. You get. So when you have vasodilation and the heart rate decreasing, remember our heart rate and the vascular resistance. If they reduce, we reduce the BP. But if at all there was a sudden drop in the BP, the reverse occurs. You have a sympathetic outflow. For an increase in the BP, you have a parasympathetic outflow. You get. So that is for the short-term regulation of our blood pressure. Then for the long-term, as I've said before, we have what we call the RAS, the renin angiotensin aldosterone system. This one usually is ushered into it for us to maintain a normal blood pressure when we have a low BP. This is one of the most things that stimulates the RAS, and also sodium. When you have a lot of sodium in the body. So when you have a low BP, blood that is going to the kidneys will be reduced. You get. So you have hypoperfusion of the kidneys. When you have hypoperfusion of the kidneys, we will decrease what we call the glomerular filtration rate. So when we reduce the GFR, we have what we call the juxtaglomerular complex. And in the juxtaglomerular complex, we have what we call the juxtaglomerular cells. They detect this reduction in the GFR, and they release a hormone called renin. You get. So renin is produced, and then it flows into the bloodstream, and renin leads to the conversion of a protein that is produced by the liver. So this protein is called angiotensinogen. Angiotensinogen is converted by renin to angiotensin 1. So we have our angiotensin 1. So angiotensin 1 also now in the body goes now in the circulation of the lungs. We have what we call angiotensin converting enzyme. and angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. You get? So angiotensin 2 has various effects. Angiotensin 2 is a potent vasoconstrictor. So it has effects on the blood vessels. It attaches onto the type 1 angiotensin 2 receptors, causing vasoconstriction. You get? It's a potent vasoconstrictor. Then it also leads to sodium retention. How? It stimulates the release of aldosterone from the adrenal glands. You get? So whenever we release aldosterone from the adrenal glands, aldosterone leads to what we call sodium retention in the renal tubules. So we retain more sodium. Sodium will be taken up, and whenever we take up sodium from the tubules to the blood vessels, whenever we take up sodium, water will follow by a process called osmosis. And when water follows, we increase what we call the vesicular compartment. And when we increase the vesicular compartment, we increase the amount of blood in circulation. We'll increase the vesicular compartment. And when we increase the vesicular compartment, we increase the stroke volume, as we are going to see on the mechanism of how hypertension occurs. But basically, this is how we regulate our blood pressure. The autonomic, where we have the baroreceptor reflex, and then the renin-angiotensin-aldosterone system, where we have angiotensin 2, a potent vasoconstrictor, also stimulates the release of aldosterone, which leads to sodium retention. Sodium retention also leads to water retention, thereby maintaining our blood pressure. So any derangement in any of these mechanisms can usher us into what? Getting hypertension. Speaking of hypertension, according to the American Heart Association, current guidelines give us this staging, and the stage whether it's normal, elevated, stage 1, stage 2, or we are in a hypertensive crisis. As we have already noted that the normal blood pressure is less than 120 for the systolic and less than 90 for the diastolic. For an elevated blood pressure, it's 120 to 129, but for the diastolic, it's less than 80. So that is what we call elevated blood pressure. Then for stage 1 hypertension, it's 130 to 139, and then for the diastolic, it's 80 to 89 millimeters of mercury. Then for stage 2, it's greater than or equal to 140, and the diastolic is greater than or equal to 90. And for a crisis, of which the crisis we look at it in front there, it's for the crisis whereby we either have a hypertensive emergency or a hypertensive urgency, depending. And we look at it, it's greater than 180, and for the diastolic greater than 100. So before you go into the risk factors and the pathophysiology, I want us to look at two basic concepts. Yes, you take the blood pressure, whereby the systolic, or yes, before you go any further, before you look at other things like the risk factors, the mechanisms of how hypertension comes about, pathophysiology, consequences, I want us to look at certain things. You know, we are looking at blood pressure, and yes, we take the blood pressure, but most of us do not focus on these two things, what we call the pulse pressure and the mean arterial pressure. And all these can be gotten from the readings of our blood pressure, from the systolic blood pressure and the diastolic blood pressure. Let us start with the pulse pressure. The pulse pressure is the difference between the systolic blood pressure and the diastolic blood pressure. What does this mean? Pulse pressure usually shows us it reflects the extent of stretching and recoil of the arteries in each heartbeat. You get? So whenever the heart beats, you get, let me draw here a simple graph. I'm going to use my normal. If this is systolic 60 and then 120, you get, whenever the heart contracts, blood is a force is exerted onto the walls of the arteries. You get, and that leads to a spike in the blood pressure. Let's say it goes up to 120, but then the heart will also relax, and when it relaxes, the blood vessels comes back to its normal. Since it has a recoil capacity and it's elastic, it's stretched out, now it's recoiling back to its normal. So, and also on recoil, a certain pressure is maintained since the blood vessel cannot collapse completely. So it comes back like this, giving us the diastolic. So it beats like that for every heartbeat. There is that. But as the blood goes on, the pulse pressure goes on reducing depending on which artery they are in. So the highest pulse pressure is in the aorta, but it goes on reducing as you go further to the arterioles and then the capillaries. You get? So this pulse pressure shows us the extent of stretch and recoil You get? So when you have a very wide pulse pressure, it means there is either an increased pulse arterial flow or the arteries are stiff. What do I mean? Either the heart is pumping with a lot of force, exerting a lot of force onto the blood vessel walls, exerting a lot of pressure onto the blood vessel walls. You get? Maybe if the normal pressure that was exerted was 120, but now it is using a lot of force and now it's giving us let's say 134. You get? And then the one down is 90. So when you get the difference here, it will be an elevated one. You get? So for the pulse pressure, the normal is in the range of 30 to 50. Usually 30 to 40, but let us go with 30 to 50 millimeters of mercury. Whenever you have greater than or equal to 60 pulse pressure, this is what we call a wide pulse pressure. You get? It indicates there is either an increased pulse arterial flow or the arteries are stiff. You get? So whenever you take your blood pressure, you ought to also record the pulse pressure. The pulse pressure can also be low, or what we call a narrow pulse pressure, if it's less than or equal to 25 millimeters of mercury. And the narrow pulse pressure, always think about, if you look at the pulse pressure, if at all you're suspecting any type of shock, whether cardiogenic, whether hypovolemic, any type of shock, usually they give us a narrow pulse pressure. You get? So that is what a pulse pressure, and it is a difference between systolic and diastolic. So when we take our normal, we have 120 minus 80. That gives us a pulse pressure of 40. You get? But now take an instance whereby we are in a crisis. 180 minus 100. Let's say that is the value we have gotten. We are having a pulse pressure of 80 millimeters of mercury. You get? So this is a very wide pulse pressure. You get? So that is always pulse pressure. Then let us go to the mean arterial pressure. So for the mean arterial pressure, this is the average arterial pressure, the average pressure in the arteries during a complete cardiac cycle. You get? The average pressure in the arteries during one complete cardiac cycle, and this one reflects the pressure that drives the blood to the target organs, or to what we call the end organs. The pressure that actually drives the blood towards organs like the brain, the kidneys, you get, to the end organs, the kidneys, the brain, the stomach, all those. The pressure that drives the blood to those organs. Usually the map is usually from 70 to 100 millimeters of mercury, and a map of greater than or equal to 65 millimeters of mercury is the one that is needed. That is why you're saying 70 to 100. It's needed for adequate perfusion of the vital organs, or what we call the end organs. But take an example when the map is low or when the map is very high. Since we are looking at hypertension, let us look at a scenario where the map is very high. You get? By the way, map is calculated from, there are two formulas. Yes, map is equal to the diastolic pressure plus pulse pressure divided by 3. That is one formula. Or we can get our map from systolic pressure plus a third of the diastolic pressure. So you see that the pulse pressure and the map are all gotten from our readings we get from measuring the blood pressure. So we get our map is equal to diastolic plus the PP, which is the pulse pressure, divided by 3. Let us take a scenario. Let us say someone's blood pressure is let's say 100 divided by 60. You get? Then here we get our pulse pressure of 40. So this is our pulse pressure. You get? So I was saying, for example, if our blood pressure is 100 out of 60 millimeters of mercury, our systemic pulse pressure will be 40. 100 minus 60. You get? Then how do we get the map? Our map will be the diastolic, that is 60, plus the pulse pressure, that is 40 divided by 3. You get? Divided by 3. So when you calculate here, you will have something like the formula, as I've said, that the formula for mean arterial pressure are these, as I've already said. So take an example. If our blood pressure is 100 out of 70 millimeters of mercury, our pulse pressure will be 100 minus, and it's within our normal range. So for us to get the map, we'll have the diastolic, that is 70, plus the pulse pressure, that is 30, divided by 3. You get this? We'll be having this is 10. We'll have 80 millimeters of mercury, which is within our normal range, 70 to 100. You get. Also, if we use this very formula, that is the systemic blood pressure, that is our systolic was 100 plus 2/3 of the diastolic. You get. You will end up with 80. You get. So that is the map. So why am I talking about the map? The map, whenever it is high, like in hypertension, if let's say we are in a crisis, when you compute, let's say 180, let's say the diastolic pressure was it's 100. Let us use this very vary. Our pulse pressure will be 20. You get. It will be 80. Sorry, it will be 80. So 80 divided by 3. So 80 divided by 3, then plus our diastolic, remember it's 100. I'm taking an example. We are in a crisis where we have 180 out of 100. You get. So we have 108 by 3, 1 by 3. We will have by 3, 1 by 3. We will have 2, 2. Still we have here 2. So it will be around 120 something, and some other things that follow. So you see that our map is very high. It's above the normal. It means like the end organs are constantly under chronic high blood pressure, like the pressure that reaches the end organs, the pressure that reaches the eyes, the pressure that reaches the brain, the pressure that reaches the kidneys is very high. You get. Because our map is chronically high due to uncontrolled hypertension. You get. Or maybe someone is in an urgency, their pressure is very high but no symptoms. So that constant high blood pressure that is reaching the end organs, it's one of the things that brings about the complications of hypertension, as we are going to see. The retinal, you can have retinal vessels. When they get nicked, you have retinal hemorrhages because the blood vessels are getting a lot of pressure, yet they are very tiny. The kidneys, the brain, you see it hypertrophying. You get, because the blood vessels in the brain become stiff, and the blood that is passing there, since they want to be able to withstand the very high blood pressure that is reaching there, will become very narrow. Hence you'll be getting less blood in the brain. You get the brain being small, things like stroke. So all that comes up because our map is constantly high due to the pressure that is very high. So that's the reason. That's why I wanted us to talk about the map and the pulse pressure, because the pulse pressure talks about the stiffness or the loss of compliance in the blood vessels and increased pulse arterial outflow of the heart. The mean arterial pressure tells us whether the end organs are chronically under a lot of pressure. You get. So now let us look at the risk factors and the mechanisms of how hypertension happens, or how the pathophysiology of hypertension. So now let us look at the risk factors that increases our chances of getting hypertension. So before we look at the risk factors, there are basically two types of hypertension. We have what we call the essential or the primary hypertension, and then the secondary hypertension. The essential hypertension, there is no known cause of this hypertension, but it's due to various interaction of risk factors. When various risk factors come together, someone ends up with the hypertension. Then for the secondary hypertension, there is a known cause, as we are going to see. So those are the two. So for the mechanisms how hypertension comes about, it's basically focusing on the essential or the primary hypertension, and this is the most common type of hypertension. So the risk factors are, and for any other non-communicable disease, the risk factors are either modifiable or non-modifiable. So for hypertension, the modifiable and then the non-modifiable risk factors are as follows. The non-modifiable risk factor that is always there, will always be there. And first and foremost, we have age. Hypertension is a disease of the old. As people age, as we undergo senescence, that is aging, our blood vessels tend to become more stiff. Remember our formula of blood pressure. It is blood pressure is equal to cardiac output times the peripheral vascular resistance. You get. So the vascular resistance increases with age. Where you have arteriosclerosis, our blood vessels become stiff and they are less compliant. So our blood pressure tends to raise. Then we have the race. According to the current studies, it's found out that the race that is mostly affected by hypertension, they are the blacks, the black people, and some Asians. You get. So blacks and Asians. The reason is usually not well known, but I think we hustle a lot. So the blacks. So if you have a family history of hypertension, let's say your mother, a first degree relative, a brother, they're having hypertension, there's an increased risk of you getting hypertension, especially if their hypertension developed during their years when they were still young, not when they were old. Family history. So these are the non-modifiable. So when you have a family history, when you're black, when you're old, you cannot modify it. You get. But the good thing is, when you're old, or when you're black, or with the family history, that does not guarantee that you get the hypertension. But the modifiable risk factors, they are the ones that are increasing they are the ones that actually are more lethal, that increases the risk more for us to get hypertension. First and foremost, obesity, especially the central obesity, someone with an elevated BMI, you get. They are at risk of getting hypertension. Smoking, cigarettes, any form of smoking, cigarettes, shisha, nicotine causes endothelial damage, and then you get. Then diabetes mellitus. Whenever you're having DM, either type 1 or type 2, DM is a requirement for atherosclerosis, forming of atheromas in the blood vessels, increasing the vascular resistance. Metabolic syndrome is the presence of 3 among the 5, that is obesity, diabetes, dyslipidemia, and some others. So the moment you have 3 of them, of the 5, you are at risk of getting cardiovascular disease, one of which is hypertension. Then alcohol, excessive consumption of alcohol, you get. Alcohol alters fat metabolism and in the long run leads to formation of atheromas. It also causes dysfunction of the autonomic nervous system, you get. And then you have excess consumption of salt, that is about greater than 6 grams a day, especially eating raw salt. Salt is basically sodium chloride, you get. So taking off salt, we are going to see how it affects when we look at the mechanisms, how hypertension comes about. Then stress, whenever we are stressed, emotional stress, stressed about children, stressed about loans, there is an increased sympathetic outflow, of which we are going to see the autonomic nervous system. How does it play in the how hypertension comes about? Yes. So after us knowing some of the risk factors, let us now look at the mechanisms of how hypertension comes about. And the mechanisms are going to be very simple. Blood pressure, as you have already noted, is cardiac output times the peripheral vascular resistance. So as we already started, we have the primary hypertension and the secondary hypertension. In primary, there is no known cause, but it's an interplay of these various risk factors, and in secondary, there is a known cause of the hypertension. So we are going to look at the mechanisms of hypertension, and this one is only going to attribute for the essential hypertension. So basically, it's an interplay of the risk factors we talked about: the age, the race, family history, obesity, diabetes, metabolic syndrome, high salt intake, and many others. So we are going to look at various factors. First and foremost, we are looking at mechanism of how hypertension can develop in an individual, and it's basically by 5 or 4 things. We have the intravascular volume. Let us start with this one. For in the intravascular volume, this is actually the amount of blood in the body, and this one is driven, or it is governed by sodium. Yes, by the sodium ions. Sodium is basically an extracellular ion, and it's the major driver of the volume of blood inside our blood vessels. So when you take a lot of sodium in, that is to say when you take in a lot of salt, we have a lot of salt in our blood vessels, you get. And remember, salt or sodium is osmotically active, so we have salt, water being pulled into our blood vessels by a process called osmosis. That is one. Salt also also plays a role in activation of the RAS, and RAS, the end products of the RAS is angiotensin 2 and release of aldosterone, which further leads to the reabsorption of salt in the kidneys and also vasoconstriction, increasing the peripheral resistance, thereby elevating our blood pressure, you get. So that is how salt affects the vesicular volume. It increases the vesicular volume. Blood being high, we increase the blood that is actually inside the blood vessels. When the blood inside the blood vessels is high, which means a lot of blood will go back to the heart. And when you fill the heart with a lot of blood, it increases the contractility still. When you increase the contractility, since also a lot of blood fill the heart chambers, will also increase the stroke volume. So contractility, stroke volume, all those are increased. It increases our cardiac output. And remember, blood pressure is equal to cardiac output times peripheral vascular resistance. So anything that increases the cardiac output increases our blood pressure, you get. So that is basically for the intravascular volume. Another thing that actually plays a role in the development of the blood pressure is the renin, angiotensin, aldosterone system. This one basically, initially it's compensatory mechanism, but as someone is chronically activating the RAS, it becomes pathological, leading to the development of high blood pressure. What activates the RAS? First and foremost, we have renin can be reduced due to sympathetic outflow, whereby you have the beta 1 receptors in the kidneys, and whenever they are activated, we release renin. Yes, we have low BPs or a low GFR, whereby little blood is perfusing the kidneys to activate the RAS. Also, sodium, that is to say our sodium ions, as we have already stated. Whenever there is an increase in sodium, we activate the RAS. So when we activate the RAS, we will have our renin converting angiotensinogen into angiotensin 1, and in the lungs, angiotensin converting enzyme converts angiotensin 1 to angiotensin 2, of which angiotensin 2 is a potent vasoconstrictor. It constricts the blood vessels. So here we have vasoconstriction, and here we have vasoconstriction, we increase the peripheral vascular resistance. So when you increase the vascular resistance, we elevate the blood pressure. Also, another thing that angiotensin 2 does is goes to the adrenal glands in the adrenal cortex, stimulating or leading to the release of a mineralocorticoid called aldosterone. Aldosterone is a mineralocorticoid that leads to the uptake of sodium in the kidneys. So sodium will be selectively reabsorbed, and when sodium is selectively reabsorbed, water will follow by a process called osmosis, you get. So we absorb water after taking in our sodium because of the influence of aldosterone. And when we absorb more water, the intravascular compartment will increase our cardiac output, thereby increasing our blood pressure. You see that the RAS affects both the resistance and the cardiac output all at the same time. Then another thing is the autonomic nervous system. This is basically the central nervous system. The autonomic nervous system, this is due to stress, chronic stress. Let's say emotional stress, any form of stress. Basically, it leads to a sympathetic outflow from the thoracolumbar region, and the sympathetic outflow means we are pumping out what we call epinephrine. Yes, and epinephrine binds onto its adrenergic receptors, of which we have the beta and the alpha. We have the beta 1, beta 2, beta 3, then we have alpha 1 and alpha 2. So the stress, which leads to a sympathetic outflow, has effects on almost every organ. It has effects in the kidneys, in the heart, the blood vessels, you get. So when epinephrine is released, it will bind onto the beta 1 receptors, first and foremost on the cardiocytes and also in the sun. Cells in the sun increasing the firing of the sun, thereby increasing the heart rate. It will bind onto the cardiocytes, increasing what we call the contractility of the cardiac muscle. This one, in the long run, increases our cardiac output. Also, it will bind onto the beta 2 receptors on the blood vessels, leading to what we call vasoconstriction. When we vasoconstrict, we increase the peripheral vascular resistance. You get, when you increase the vascular resistance, it elevates the blood pressure. Also, we have beta 1 receptors in the kidneys. When epinephrine binds onto them, there is release of renin, and whenever we release renin, we activate what we call the RAS, and the end product of the RAS is angiotensin 2 and aldosterone. Angiotensin 2 is a potent vasoconstrictor. So in addition to the vasoconstriction caused by the epinephrine, we have angiotensin 2 still acting, causing further vasoconstriction, and also release of the mineralocorticoid aldosterone from the adrenal cortex. This further increases sodium retention and then water retention, increasing the cardiac output. So all these lead to an increase in our blood pressure. Last but not least, we have the vascular mechanisms. Vascular. This is basically blood vessels. And blood vessels, we have already seen there is vasoconstriction from the RAS and also from the autonomic nervous system. And vascular mechanism, this one deals with the functionality and also the structure of the blood vessels. So functionality is altered in a way due to the influence of epinephrine and also angiotensin 2. We have constriction of the blood vessels, altering the functionality. Then the structure, we can have formation of atheromas. Yes, atherosclerosis, whereby you have plaque buildup inside the blood vessels. This narrows the lumen of the blood vessels, and when the lumen is narrow, the blood pressure increases. Or it can be due to arteriosclerosis, whereby now the walls have become stiff. The walls become stiff first and foremost as we age. Age is the number one factor. As you age, the blood vessels become stiff. Hence, they are less compliant. Their ability to give way when blood is passing through, their ability to give way, yes, is reduced significantly due to arteriosclerosis. So they become more stiff, and when blood is passing through, a lot of pressure is exerted onto these walls of the blood vessels, therefore altering either the functionality or the structure of the blood vessels. So these are some of the mechanisms of how this essential hypertension comes about. It's an interplay of the intravascular volume, the activation of the RAS, autonomic nervous system, and the vascular mechanism, whereby you alter the functionality or the structure of the blood vessels. But all this is brought about by the risk factors we looked at: things of race, things of family history, things of age. We have DM, obesity, smoking, high salt intake, and others. All those, when they come into play, they bring about these effects, and someone will end up with a raised blood pressure because the cardiac output and the vascular resistance are increased. So now let us look at the secondary causes of hypertension. Remember here. So now for the secondary causes of hypertension, or what we call secondary HTN, here we have known causes. Known causes, and I'll borrow an acronym from Ninja Nerd. It's RENOS. Yes, we have renal causes, endocrine causes, neurological causes, adrenal causes, little people, and then substances. So let us start with the renal causes. The kidney, first and foremost. The kidney can cause hypertension, but it can also be affected by hypertension. So in case you have a kidney disease, for example, chronic kidney disease or renal artery stenosis, both these can lead to an elevation in the blood pressure by activation of the renin-angiotensin-aldosterone system. Chronic kidney disease, whereby your GFR is significantly reduced, and whenever the GFR is reduced, there is reduced perfusion of the kidneys, and when you don't perfuse the kidneys properly, yes, the RAS will be activated, whereby renin is released, and when renin is released, is an enzyme. Let us not go back through the RAS. We know all what happens when the RAS is activated. Then in renal artery stenosis, whereby the renal artery, the artery that feeds the kidney, is narrowed, and still when it's narrowed, the GFR will drop, and still will activate the RAS, and you know the effects of the of the RAS. Then another one is the endocrine causes, and for endocrine causes here we have thyrotoxicosis, hyperthyroidism, endocrine disease, whereby you have hyperthyroidism, whereby you have elevated levels of T3 and T4. Remember, someone with hyperthyroidism, they'll be having an elevated basal metabolic rate. This comes with an elevated heart rate, you get. So when the heart rate is reduced, remember, heart rate affects our cardiac output. From where? Remember, cardiac output times peripheral vascular resistance, and cardiac output is affected by what? The stroke volume times the heart rate. So when we have an elevated heart rate, we can increase our cardiac output. So hyperthyroidism can present with what? Can give us someone having a high blood pressure. So coming from endocrine causes, we have the neurological causes. Here we have basically one that is an elevated intracranial pressure. Yes, hypertension is one of the triad, what we call the Cushing's triad. Whenever someone's ICP is elevated, they will have bradycardia, irregular respiration, and hypertension. This could be an elevation in the intracranial pressure, can be due to anything that any space occupying lesion inside the cranial vault can lead to an increase in the ICP. So it's one of the causes of secondary hypertension. Then another thing are the adrenal diseases, adrenal disorders, you get. So the adrenal disorders, these are very many. First and foremost, we have what we call primary hyperthyroidism. Not hyperthyroidism. We have primary aldosteronism. This is whereby there is excessive production of aldosterone from the adrenal cortex, and aldosterone is a mineralocorticoid. It leads to sodium retention, and sodium retention is followed by water. We increase the vascular compartment, we increase the cardiac output, and thereby we elevate our blood pressure. Then we have Cushing's syndrome, whereby you have excessive production of excessive glucocorticoids, cortisol. And cortisol, since they are all coming from the adrenal cortex, they mimic aldosterone, and they bind onto the aldosterone receptor, still leading to sodium followed by water retention, in the long run causing hypertension. Then we have what we call ethiochromocytoma. This is a tumor in the adrenal medulla. You know, in the adrenal medulla we have, when you have our kidney, you have the adrenal gland sitting on top of the kidneys, whereby you have the cortex and then the medulla. In the medulla is where you have produced adrenaline. So when you have a tumor in the adrenal medulla, it's pumping out tons and tons of adrenaline, of which adrenaline binds onto its adrenergic receptors, first and foremost in the heart, in the kidneys, on the blood vessels. In the heart, increasing the heart rate, contractility, blood vessels leading to vasoconstriction, the kidneys activating the RAS. All that can lead to an elevation in the blood pressure. Then little people, that is basically pregnancy. This is for pregnancy, and this one is mainly attributed to preeclampsia or eclampsia, due to the abnormal invasion of the placenta into the uterine wall. You get preeclampsia. Look at it in our obstetric videos. Then substances. There are substances whereby when someone takes them, they lead to vasoconstriction and other things. For example, cocaine, caffeine, and others. So these are some of the causes of secondary hypertension. There is actually a cause of why the blood pressure is high. The renal causes, CKD, renal artery stenosis, hyperthyroidism, increased intracranial pressure, adrenal disease, primary aldosteronism, Cushing's disease, and the ethiochromocytoma, eclampsia in pregnancy, and substances. So let us now, we have looked at how blood pressure comes up, the secondary causes of hypertension, and then now let us look at the complications of hypertension. What could be some of the consequences, the pathological consequences of this hypertension? So we are looking at the pathological complications of HTN. Remember, I looked at the stage whereby you have elevated blood pressure, stage 1 hypertension, and then stage 2, and then we had a crisis. You get. So what could be the pathological complications of uncontrolled hypertension? You get. The pathological complications of uncontrolled hypertension. Remember, we talked about what we call the mean arterial pressure and what we call the pulse pressure. And we say that the mean arterial pressure is the average blood pressure that drives blood to the target organs, and it's in a range of 70 to 100. You get. So when the mean arterial pressure is chronically elevated, it means a high pressure. Yes, we are having, let's say if this is our heart. Yes, if the mean arterial pressure is chronically elevated, it means the pressure that is reaching the end organs is also chronically high. That is to say, the eyes, yes, the kidneys, the heart itself. It means like they are receiving a lot of pressure from the heart, whereby a lot of pressure is reaching the end organs. So this is basically one of the reasons as why you have end organ damage. So starting with the heart, there are effects that occur on the heart itself. You get. Remember, you have an increased vascular resistance, so the heart will find it hard to pump blood out. So it will adapt by undergoing a process called hypertrophy, and the hypertrophy usually happens on the left ventricle. So we have left ventricular hypertrophy. You get. So left ventricular hypertrophy can happen because the heart is pumping against constricted blood vessels. So it has to come up with a force to overcome the resistance. So it undergoes left ventricular hypertrophy, whereby the left ventricle becomes thick. And whenever it becomes thick, yes, let us say this is our heart, and this is our left ventricle, then this is our right ventricle thing, then this one is thick. Since it's pumping against an increased vascular resistance, it will undergo what we call hypertrophy. So its muscle thickness will increase. So when it increases, yes, the ventricular chamber will reduce. And whenever the ventricular chamber reduces, it means it will be filling with less blood. When it fills with less blood will be pumped out. You get. Less blood will be pumped out. And whenever the heart is not pumping enough blood for the body's demands, it is called heart failure. So from left ventricular hypertrophy, we can come up with congestive heart failure. You get. So we are first on the heart. We have left ventricular hypertrophy. From left ventricular hypertrophy, we can get congestive heart failure. And also, since the muscle has become more thick, it will need more requirement of blood. Remember, the heart itself requires blood for it to pump. But since this muscle has become more thick, its requirement will also increase. And whenever we do not have, like, the requirement surpasses the supply of blood, we'll come up with a disease called ischemic heart disease. You get. It can be also due to coronary artery disease, whereby the coronary arteries have also become stiff due to formation of atheromas, or due to atherosclerosis, let's say in someone, BST, DMO, metabolic syndrome. But also when the demand has surpassed the supply, we can also come up with ischemic heart disease. So in the heart, we can have left ventricular hypertrophy, congestive heart failure, and ischemic heart disease. And also we can come up with problems with conduction of impulses to the heart, where we'll get arrhythmias in the heart. So in the heart, the effects of hypertension can be left ventricular hypertrophy, what we call hypertensive heart disease, which can progress into congestive heart failure, it can also give us ischemic heart disease, and also give us some arrhythmias in the long run. So in the heart, we basically have that. And also the major cause of the deaths in hypertension that are secondary to the heart is basically ischemic heart disease. You get? So the heart is affected in this way. Which other organ can get affected? So the other organs that can be affected in the hypertension is the brain. You get? Whereby now in the brain we have various things. For example, the leading is stroke, and mainly we have the ischemic strokes, but we also have what we call the hemorrhagic stroke. We will look at the stroke videos individually, but basically in ischemic stroke we will have a clot, a thrombi, due to formation of plaques in the various blood vessels. You can have a thrombi breaking off and then becoming an embolus traveling to the brains of the blood vessels, and since they are very tiny, it can clog, cutting off the blood supply to the distal end, giving us an ischemic stroke. Like, remember I told you, like, the MAP is chronically high, so also the blood vessels in the brain will try to adapt to withstand this high blood pressure, and they will undergo what we call hyaline atherosclerosis, whereby now they can withstand the high blood pressure that is coming from the heart. By doing so, the lumen will also become narrow, and also the blood vessels become stiff. They do not give away. So when this thrombi or with this emboli comes, it can easily occlude the lumen, which is already tiny, cutting off blood to these other parts, giving us a stroke. Hemorrhagic strokes can happen because the blood pressure is very high, the blood vessels can become very weak, the walls become very weak, and due to the constant high blood pressure, they can give way and burst, leading to oozing of blood out, cutting off blood supply to the other region, hence giving us a hemorrhagic stroke. You get? Then we can have brain atrophy of the brain, giving us things like dementia, because the brain is not being supplied with enough blood. It will atrophy, such that on atrophy, because less nutrients are reaching the brain. So when less nutrients are reaching the brain and also atrophies, you have problems with remembering, problems with cognition. So we have some things on brain atrophy because the blood vessels have become tiny to withstand the blood pressure that is coming from the heart. Then another thing that is very, very interesting, we have what we call a hypertensive encephalopathy. Yes, a hypertensive encephalopathy. Hypertensive encephalopathy usually is a very, very serious condition. It usually happens when the blood pressures are very, very high. This one is very common in eclampsia, whereby someone now has seizures. They seize due to elevations in blood pressure. It's actually hypertensive encephalopathy. And what actually happens during this process, you get? So basically, the brain is we have our brain here. Yes, that's a very small brain. So this is our brain. This is our brain stem. Then this is our cerebellum. Yes. So blood to the brain, the perfusion of the brain is, the MAP is usually between 50 to 150 millimeters of mercury, and the perfusion to the brain is regulated by a mechanism called autoregulation. You get? So autoregulation works in a way that when the blood pressure is high, this marker is out. When the blood pressure is high, you get? When the pressure coming towards the brain is high, these blood vessels constrict. So when there is a high BP, the vessels, the cerebrovasculature, constrict. You get? They constrict such that less blood reaches the brain. And then when the blood pressure is low, when the BP is decreased, they relax such that they become big, such that a lot of blood cuts to the brain. So by doing so, they maintain a perfusion of the brain such that it is not altered, because the brain has to be receiving blood in its actual amounts, not very high, not whereby the MAP is not very high and also not very low. So when the blood pressure is low, they vasodilate such that they maintain the perfusion. When it's very high, they constrict such that less blood reaches the brain. But now when the map is very high, for example in BPs of let's say 200 out of 120, you get, or it can occur at as low as 160 over 100. When the blood pressures are this very high, the autoregulatory mechanism fails. You get, it is cut off, it fails. Now it happens whereby when it fails, the blood pressure, remember during autoregulation the cerebrovasculature constricted, but now when there is an increase in the cerebral perfusion or the blood pressure, they are now going to just dilate, cause the autoregulatory mechanism has failed. So when they dilate, we'll have a lot of blood perfusing the brain. You get, so when a lot of blood goes to the brain, we'll have what we call cerebral edema. You get, so when a lot of blood goes to the brain, we'll have extravasation of fluids from the blood vessels to the brain parenchyma. When there is cerebral edema, we'll have what we call the gyri will flatten. You know those creases, those mountains and hills on the brain, they are like this, so they will also flatten. So secondary to cerebral edema, will have the gyri flattening, and then someone will end up having neurological symptoms. They'll have an intense headache, they'll have scotomas whereby there is a region in their visual field that is blurry, they'll have diplopia, sometimes they'll even get seizures like in eclampsia. Remember, we have pre-eclampsia before seizures, but if not managed, we go into eclampsia. So this is what happens, and to the brain, that is what actually happens. And hypertensive encephalopathy can happen in pregnant people, like in eclampsia. It can happen when someone gets off medication rapidly, where the BP rises rapidly since they have left the blood pressure medications rapidly. Someone with a pheochromocytoma, whereby there is pumping of adrenaline out of the adrenomedulla, and very many other things. So in the brain, we have stroke, brain atrophy, and hypertensive encephalopathy, and very many others. So have effects on the heart, on the brain. Then there is also another organ that is affected. It's in fact part of the brain. You have the eyes, whereby you have the eyes. The eyes are also affected. They are also end organs. They are affected by this elevation in the blood pressure. We have the blood vessels supplying the retina can undergo hemorrhage, whereby on fundoscopy, or when you do fundoscopy using an ophthalmoscope, we have herniation of the optic disc. We'll have retinal hemorrhages, nicking of the retinal blood vessels. All that can happen in the eyes. So also the eyes can be affected. We can have the kidneys also can get affected since they are under chronically high blood pressure. We can have hypertensive renal disease. We can have the blood vessels themselves, blood vessels, whereby this one you are going to see it in the crisis. So you can have aortic dissections, and you can also have aneurysms being formed. So hypertension has very many effects on the body. That's why it is essential for you to go and get screened. Remember, blood pressure or an elevation in blood pressure does not have any symptom. Usually the symptoms come to surface when there is actually a complications, among which we have looked at, but usually in the first phases there is no symptom. The symptoms usually come up when there is already damage going on to the end organs. Maybe you're not urinating enough, maybe you're having blurred vision, you're having headaches, that's when the symptoms can now come onto the surface, and then you say, I may be having something wrong. But the moment you're supposed to go for blood pressure checkups to know, is your blood pressure high? Even the young people, yes, blood pressure is a disease of the old, but also the young people, you ought to go to get your blood pressure checked.